Hi everybody, my name is Dr. Ollie Burton. I'm a clinical research fellow in neurosurgery, currently working in the NHS. I'm going through my own specialty application process, so this is part 2 of a Q&A answering your questions about how specialty training or residency works in the UK. Be sure to go and watch the first part. If my answer to your question doesn't come in this video, it may be in that first video, and you'll be able to see in the timestamps which questions I'm answering. If I haven't answered your question, please do leave it down in the comments below and I'll get to it as soon as I can. And let me know what specialties you're applying for, it would be really good to hear from you. Zach Penn Praise 25 wants to know, what specialty inside neurosurgery are you interested in? I'm not sure, just based on the question, exactly whether this means what subspecialty are you interested in within neurosurgery, or what specialty aside from neurosurgery are you interested in, and I'm going to try and answer both together. Aside from neurosurgery, I have also applied for radiology training, and that would be with a view to pursuing what's called interventional neuroradiology, or INR, increasingly doing a lot of work that historically was done by neurosurgeons. It's a much shorter training pathway relatively to neurosurgery. I think it would give me a lot of what I want, that is very procedural, it's the right organ system for me. Radiology renowned for being a very, very good training program. So we'll see. We're at the beginning of the process. If I got offered a radiology training number and I didn't get offered a neurosurgery training number, on balance I think I would probably take it and then reevaluate once I had started training, but we'll see. It's a flux process. Coming to which subspecialties inside neurosurgery am I interested in, what we might call the subspecialties. I've spent the last 4 months working on a complex spine unit, and I actually really enjoy spine surgery. A lot of neurosurgeons don't like it, and obviously when people think of neurosurgery, a lot of what they think of is the really exciting intracranial stuff, aneurysms and tumours and things. But spine surgery is really, really important, and really important that it's done well. Things like lower back pain, chronic back pain, enormous workload in the UK. One of the most common reasons that people are off sick long term from the workforce or unable to work due to crippling back pain. And so that is an area where I think I could see myself making a difference. Pediatric neurosurgery is really where I'm hyper interested academically. And that's something I'll talk about in another video, but that comes down to my earliest experiences of neurosurgery, spending time with the neurosurgeons as a medical student and seeing how those surgeons interacted with the parents of children that were going to be undergoing cancer surgery. And that was just so mind-blowing and eye-opening for me. It's really had a significant impact on how I perceive how surgery is done and how surgery is communicated. So I hope between all of that, I've answered the question. Brett McKenna wants to know, what's the least competitive specialty to apply for? And lots of other people have asked, what's the most competitive specialty? So to start with the reverse, the most competitive specialties year on year tend to be cardiothoracic surgery and neurosurgery. Cardiothoracic tends to beat neurosurgery to the post in only having between like 7 and 10 training posts per year for the entire country. So the competition ratios are crazy. The people that do it are immensely dedicated and competitive to get in. In terms of least competitive, it's really difficult to answer because it tends to fluctuate. You can just Google specialty competition ratios, say 2023 for this year's intake. Historically, I would suggest it was probably GP, given that there are vastly more training posts for GP than any other specialty, which brings down the competition ratio, if competition ratio is the metric that we're going to use for competitiveness. That being how many people are applying to it for the number of spaces available. So if you've got 2 training posts available and 10 people apply for those 2 posts, you'd have a 5-to-1 competition ratio. And then more broadly, I think we just need to consider the sorts of things that drive competition ratio being what they are. A lower number of training posts will always give you a higher competition ratio, perhaps artificially inflate it. Equally, lots and lots of people wanting to do a particular specialty will increase the ratio. And then you need to think about why different people want to do different specialties, because the reason that lots of people want to do, say, plastic surgery or dermatology, for example, where there is huge private market potential, might be different to the reasons why loads and loads of people want to do cardiothoracic surgery or neurosurgery, where there is still private potential, but it will be less of your workload. And I think we need to consider all of these things and how they play into competition ratios to understand the groups of people that we'd be competing against if we were trying to get a place. Louis Nickel wants to know, to which specialties does the MSRA apply to? Now, the MSRA, the bane of my life, the multi-specialty recruitment assessment, is a general medicine exam that was piloted and validated for GP, so general practice. It's a national exam. If you think about something like the USMLE, a national general medical exam which tests the entire depth and breadth of the curriculum, that was initially used to select general practitioners, because general practitioners were going to do general medicine, so it makes sense that the better people do on a general medicine exam, the better GPs there might be, especially in view of GP having quite a short training pathway. The problem now is that psychometricians have somehow got this exam to be used across a whole range of specialties that don't require such a good breadth of general medicine knowledge. So this GP exam is used for neurosurgery selection, it's used for radiology selection, it is now used for core surgery training selection, which is completely wild. It's not used for internal medicine training yet, although it would not surprise me at all if that was a change that we see in the next few years. And obviously it's used for GP. I'm sure there are more that it's used for, I've just not looked into it. But the problem with this exam basically is that the MSRA is a blunt, non-validated tool for most specialties that is now used simply to whittle down and get rid of applicants so that fewer people can be interviewed. That is the function of it. It has no predictive validity whatsoever in most settings in which it's used. It's simply used to get rid of people to save money and time when going through applications. Jose Carlos wants to know, if you're an IMG orthopedic resident, do you know how it works if you want to continue your training in the UK? It's a good question, and lots of people want to do this. Lots of people are already residents in training in some specialties in other countries, or they might want to come from another country to start residency, specialty training in the UK. The real bottom line to this is you would need to work out, if you're an IMG resident, an international medical graduate resident, you need to work out if you are eligible to apply for higher specialty training in the UK and start from the beginning. So if you're already an orthopedic resident, what you need to do is work out whether you are eligible to apply for orthopedic higher specialty residency training in the UK. Because if you are, that's going to be the simplest thing to do, and although you often won't be able to transfer your competencies and pick up when you left off, you'll effectively be starting from the beginning again as an orthopedic resident in the UK, an orthopedic trainee. That would probably make things the simplest, because you would be considered a trainee like everyone else. Like a UK trainee, you would be prioritised for training and progress towards becoming a consultant like anyone else. That's probably the most simple thing you could do. If for whatever reason you are not eligible to apply for training, you can come and work as a fellow or a locally employed doctor in your specialty in a hospital, and then what you would need to do is look at something like what's now called the portfolio pathway, what used to be called CESR, which is basically applying to have your competencies that you already have, the training that you already have in your country, recognised within the UK, and then working out what you need to do to finish your training in the UK. And you would need a department and a supervisor who is willing to support you doing that. The other thing that you should look at are the SAS doctor careers, specialty and associate specialist grade doctors. And there are two tiers of this. There are specialty doctors who have less experience in a specialty, if you are already a senior resident in your specialty, you may be eligible for what's called the specialist doctor contract, and this is more in line with a consultant or attending. Requires you to have worked at least 12 years postgraduate, 6 in your specialty. So basically those are your 3 pathways. You can apply for specialty training in the UK like everyone else. You can work as a fellow, a locally employed doctor in a hospital in the UK and be supported towards joining the specialist register and becoming a consultant and attending that way, finishing your training. Or you could work in a SAS doctor contract, either at the lower or higher tier, or starting at the lower tier and working to the higher tier, and then again joining the specialist register and becoming a consultant if that's what you want to do. Parth wants to know, why is London so sought after? I guess the answer will just be because London is the most desirable place in the UK to live for most people, you know, the capital city, I guess, like any country. Why in medicine? I suppose because it's got these big tertiary academic hospitals that are world leaders in the things that they do. They have the most money, prestige, power, probably academic success that comes by virtue of being in London, where the most funding is. And then because you have the most funding, the most prestige, the most success, you're doing all of this innovative work that continues to breed more success, right? Because success generates more success. Once you've got that name, you're going to keep bringing these world experts. Like I work at the National Hospital for Neurology and Neurosurgery. It's one of the best neurosurgical hospitals in the world. So therefore people are going to keep wanting to come and work there in the UK. In terms of the actual quality of training, and to be clear, I'm not talking about my hospital here because I'm not a trainee, I can't comment. It is not necessarily the case that these big academic central London centres will give people the highest quality training. Certainly in surgery, actually, it's well known that in London you will probably do fewer surgical cases working in London because there are more people there than if you were working in a district general hospital where you would be expected to do a lot more of the general work. So why is London competitive? I suspect probably a combination of it's where most people want to live just by virtue of being the capital city, and it has these big academic centres that are doing things that no one else is doing, that they have by virtue of being big London academic centres. Hero wants to know tips to get into neurosurgery. I'm just going to answer this in the general case because the tips to get into neurosurgery are going to be the same as the tips to get into any other specialty. Basically, the answer will always come down to you need to read the person specification for the specialty for which you are applying, because that has all of the answers that you need, and the answers are mostly going to be the same. Publish some papers, maybe pass some exams, have some additional degrees, do some teaching, do some audits and quality improvement projects, but the specifics of what you need to do are going to be tied very specifically to what that specialty wants at that particular point in time. So for example, 3 years ago, having your MRCS and having an additional degree would have got you some more points on your surgical training application. As of 2023, those things no longer do because they change every single year. So instead of me giving advice beyond what I've already said that's very generalist, that will not stack up in a year or two's time, at the time you're asking, you should go and check the specialty shortlisting and the point scoring portfolio matrices, because that's going to give you the information that you need. IS wants to know how much of a portfolio is enough for less competitive specialties like O&G. I don't know that O&G isn't competitive. I thought it was, but that aside, basically it's impossible to answer because it ultimately will depend on the people that you are competing against. What will happen at several stages through the application process, there will be long listing and then short listing and then interviews and so on. So what might happen during the long listing phase is everyone submits their portfolios and then they decide that they're going to take at O&G headquarters, that they're going to take forward the top 600 people. So if your portfolio happens to be good enough to be in the top 600 people, you might move on to the next stage, and if it's not, then you're out. It's really impossible for me or anyone else to say how good a portfolio do I need to get XYZ, because it's completely unpredictable, and it depends what has happened in that given year and if the portfolio scoring system has changed. A. Harrod wants to know, is it true that if you get rejected once, you're less likely getting accepted if you reapply? As far as I know, no. I don't think there's any way of specialty selection systems tracking that, or indeed what would be the point particularly. The only thing they really do to stop serial applicants going on for years and years and years is there are often limits in how much experience you can have. So in neurosurgery, for example, you are only allowed to have a maximum of 12 months of post-foundation neurosurgical experience. So you might have done a neurosurgical job in F1 or F2, your first couple of years out of medical school. Then once you get beyond that, you have a time limit of 12 months of experience, and once you get to that 12-month mark, you can't do any more clinical work in neurosurgery, neurology, or neurointensive care. If you want to keep applying for neurosurgery, you could spend years and years and years doing other things and continuing to apply for neurosurgery. So you could go and work in acute medicine for a year and apply again. You could be a teaching fellow for a year and apply again, doing something else. But the moment you go over that 12-month limit, you become ineligible to apply for ST1 neurosurgery training. So that is, I guess, the only way of them restricting people getting ever-increasing amounts of experience before applying. Your only choice at that point would then be to go into the CESR portfolio pathway system, or working as a SAS doctor if you want to continue working in neurosurgery and working towards independent practice. And then there's genuinely like 25 questions asking, how do I make myself more competitive? So I'll just spend a bit of time addressing that. So as I've said before repeatedly, being competitive for one specialty is not the same as being competitive for another, and that changes year by year. I went genuinely from being a very, very good applicant to radiology based on the work that I'd done for my surgical application to being like a useless applicant, very uncompetitive, simply because the portfolio marking system changed to make everything radiology specific. So things can change very, very quickly, and the landscape can change, so you need to be constantly keeping up. But the second thing to say is that some of the domains, if you look at what the different specialties ask for, and you need to again look at, hematology, person specification shortlisting, neurosurgery, person specification shortlisting, general surgery, person specification shortlisting, because if I answer in detail about any of them, it's going to be wrong in a year's time. They will have changed again. So just look and Google for it. But the domains that repeatedly come up as being considered important year to year, bearing in mind again that the terms can change, are things like audits and quality improvement projects. Audits are looking at how well your department is performing and measuring it relative to some sort of standard. So if the NICE guideline for epilepsy suggests that all first fit presentees should be seen in, I don't know what it says, 2 weeks within an epilepsy clinic or something, then how well is your department doing? Do your surgical consent forms in your department have all of these material risks that might be recommended by your surgical specialist society? Are all of your inpatients on low molecular weight heparin for venous thromboembolism prophylaxis? There are lots of different audits and quips and things that people do, but they tend to appear across specialty. Teaching is also a really common one that appears across specialties, so that would be designing some sort of teaching program that's run regularly, perhaps twice a month, over an extended period, so say 4 to 6 months. Again, you need to look at what the specialty wants. Leadership is also a common one. Do you have a society role? Were you president of anaesthetic society at medical school, or street doctors or something? Were you a BMA representative? Did you work with a charity at the regional or national level? Do you have some kind of leadership experience? Have you run a course that lots of people have attended? And then the last bit tends to come in publishing and academic work. So have you authored some publications and published them in a PubMed index journal? Ideally, you would be first author and it would be in a journal relevant to the thing that you're applying for. Have you presented at national and international conferences with a mixture of poster and oral presentations? Again, These things tend to fit the marking criteria across multiple specialties if you're not sure what you want to do. So if you're a medical student or a foundation doctor, any academic work is good work. Anything is better than having nothing. Pick projects that are small, achievable, that you are going to get finished and done and presented by the time the applications come around. I've done plenty of portfolio building videos before. If you want me to do an up-to-date one, that's fine, let me know. But a lot of the advice is going to be the same as things that I've already said. And the last one that I'm going to answer from Jamie McParlin is it worth it? And that, I think, is a really interesting question, because it won't be for everyone. Going through the rigmarole of getting a national training number, especially in some specialties, may not be worth it. Why would you want to do specialty training? Because it is the simplest, arguably, most well-trodden pathway to becoming a consultant, to being an independent senior doctor with maximum responsibility and earning potential and financial stability, and to be at the peak of your clinical practice, I guess, is the reason why people would want to do it. It's how to become the de facto senior within your field and the leader of the medical team, as doctors are supposed to be. Is it the only way to do that? No. And this will depend on your circumstances, but there are other ways to independent practice and becoming a senior doctor and joining the specialist register. I've talked about them at length before, but SAS doctors are well worth knowing about. So specialty doctor, you need to be 4 years postgraduate, having worked at least 2 of them in a specialty that you are going to become a SAS doctor in. So I'm currently doing a year of neurosurgery. If I did another year after that and did an F4 working as a neurosurgical SHO, then I would be eligible to become a SAS doctor, a specialty doctor in neurosurgery, which has its own national terms and conditions and contract. If I wanted, I could work in a supportive department towards independent senior practice over many years towards the specialist contract, so 12 years postgraduate, 6 in neurosurgery, assuming that I met all of the competencies required to do so, and I would need someone to train me in order to get there. And once I was there and working at that sort of level, I could apply through historically what was the CESR process, CSER, what's now called a portfolio pathway, to join the specialist register as a neurosurgeon, and that would allow me to be appointed to a substantive consultant post, and I could become a neurosurgical consultant just like anybody else who had completed traditional training. And you can apply that to any specialty you want. The reason why people want an NTN is that as long as you put the work in, NTN being a national training number, and meet your benchmarks, you are essentially assured to make it out the other end and be eligible to become a consultant. There's a lot of security and protection that comes with that, much less so, unfortunately, with the other pathway. People who are outside of that pathway tend not to get prioritized for training and will be less supported towards that independent practitioner status, which is sad, but it's just the way it is, although there is a lot of work that's going in to change that. So that's why. Is it worth it? I think for most people it is, but there is a sizable percentage of people for which it won't be the best thing to do, and alternative pathways in or outside of medicine may be the best thing for them. So thanks very much for watching, guys. Please be sure to hit that like button for me, leave a comment, subscribe. If I've not answered your question, let me know down below. What are you applying for? Let me know, and good luck with the MSRA for all of those sitting. Take care.